It threw me on the other side, hit over here, I hit on the occipital region. There was so much of bleeding, but better now. What he did is there was a grave mistake. Just for the understanding, let's say this is drawing room, this is, let's say, kitchen, this is bedroom 1, this is bedroom 2, this is like our computer room, and here is a hall. Now over here, every junction, it would come over here, every junction, right? I mean, there'll be multiple lights, etc. But final one will come over here. And they are connected with what's called as the MCB. And MCB stands for miniature circuit breaker. So there is a panel of MCBs, right? Each panel is representing one room. Now, miniature circuit breaker's function is just to switch it off. You can connect it even on your AC also, right? Anything which is more than 1000-watt load, so you can connect a MCB. It is more safe because the contact points, they are spring operated. So fatak, right? Tak, in 1 second, it will, in 1 second is more. In fraction of a second, it will switch off or switch on, right? So the contacts are much better, stability, life, everything is fine. But apart from that, there is no other extra thing. It is called a circuit breaker. Circuit breaker matlab apna switch. The thing which we are doing it with normally on or off, over here there is a spring. But then all of them, they are connected to one more unit. It is called as the ELCB. On our all 3-pin plugs, there is one live terminal, second one which is called as the neutral, and third one which is called as the ground. The function of ground is that in case if there is any current leaked from the circuit, it will be grounded and it will go on in the ground, and no one would be injured. But for that duration, current will be passing from our body. The current will be passing from our body for that short duration. In order, and now that is when we'll be learning cardiology, we'll see that this extra current will actually, it will make major imbalance into your sodium potassium pump. So large amount of ions, they will be entering into the heart, and that can lead to all cardiac arrhythmia. It is called as cardiac arrhythmias. In order to counter this is called as ELCB. That is what is called as the earth leakage circuit breaker. So that means the moment it is defined or it is identified that current is getting leaked via incorrect path, within fraction of second it would disconnect, right? The duration of action is 0.01 or the 1 milliseconds, 1000th part of a second. So it is just 1 millisecond. For 1 millisecond, you won't even feel like that cheetah ne kata. It is that less. Now I have put on my ELCB on extreme sensitivity mode. It is on extreme sensitivity. That means even with the slightest leakage, it trips. That person what did was, he said, sir, बार बार वो trip हो रही थी ना, so I bypassed it. He bypassed this unit. It is like now till entire electricity in the house, if it is working fine, but अगर जो किसी को current लगे, तो then that person would die there because there is no breakage. It is bypassed. He went, right, because there was one geyser to be fit, so he said he finished it. He went. Never told me that this is bypassed. And when during my automation part, because in automation, there are some circuits which are not requiring the neutral wire. They use the ground as a neutral wire. So that way, ground is everywhere. So you just put the live wire and then the ground will be acting as a neutral wire. And ELCB won't be getting affected. It is because of its pulse wave. In that process, I touched this live wire because there's nothing No problem at all. You can do that, right? Because you are wearing rubber slippers and because you are not touching, the best example, high tension wires are there और बंदर उसके ऊपर लटक लटक के जाते हैं. Nothing happens because it is not grounded, right? Circuit is not complete. So on this live wire, even if you touch it, nothing would happen, right? Not even slightest of the current. And in case if this thing is touched, any of the other wire is touched, then LCB is there, it will trip. By mistake, it happened like that. When multiple wires are there, right? On one board there were 40 wires. One of the wire, it just touched me over, it create a burn and ELCB didn't trip. So I was CD pe, I was on the third step. From that third step, I fell. पीछे was like, got injured. So I was not fine for almost 15-20 minutes. After that, I called him up. Immediately, I checked that ELCB is at problem. So when I saw it was at bypass mode. So this is just, you should really know. And for them, it was so casual कि हाँ वो भूल गया था. Anyway, so let's start with our today's topic. So today we'll be talking about osteology. In osteology, we'll be covering these two bones. One, what is called as the clavicle, and second would be the scapula. Now, there are two methods to learn anatomy. One of the method is that first straight away you start learning the bones. In that, what happens that when we learn the bone, we keep on imagining that, okay, coracobrachialis hoga koi, right? Brachialis hoga koi, pectoralis major, pectoralis minor. And then when the similar names, they start appearing, actually you have to cram. That's why we changed the approach. First, we saw the structures, and now you'll find that this would be the easiest session, right? This would be the easiest session. And take my word for it, definitely, you will be able to answer almost all the questions. There are just one or two things which you have to just take care of. Otherwise, it's a very comfortable, smooth session. So let's start. Clavicle and scapula. Very much in general, just the bones, and we know clavicle, we know clavicle, we know acromion process, we know coracoid process, right? Greater tubercle, lesser tubercle, and in between there is intertubercular sulcus, and obviously the first rib which will be connected to T1, that is thoracic 1, and then C7, C6, C5, C4, till whatever the level till we can see that, because then C3, C2, and C1, we have to watch from the opposite side, because here the jaw is coming in between, mandible is coming in between. This is manubrium, this is sternum, and this one would be the xiphoid process, right? And all the ribs, and these are the anterior end of the ribs, because these anterior end of the ribs, then later on you will see that they are connected with the costal cartilage, and that costal cartilage will be connected to the sternum. Just for a quick reference, 1 to 7, you know what it is, 8 to 10, you know what it is, and 11 to 12, it is, right? These are the true ribs, these are the false ribs, and these are the
Floating.
Yes, these are floating ribs. False ribs. False ribs, they are not made in China. They are just because their anterior end is connected to the 7th costal cartilage. Okay? 11th and 12th, yes, you say that. They are floating. Now, this question, it will, when examiner wants to pass you, it's not so that it is like in case if they ask you any of the question on clavicle, so then they are doing that. But usually it is said that if you want to pass someone, to then give clavicle to him. Take it other way around. If you are not knowing clavicle, it is difficult to pass, because this bone is pretty simple. Not only that, identification is easy, And third thing is the muscle attachments, they are very peculiar. So you don't have to stress so much. So if someone is making blunder in this, to gaya kaam se. Right? So that's why these are the areas. मतलब जो कहते हैं ना कि easy ball पे अगर जो out हुए तो पूरी दुनिया गालियां देती है. Same thing is here. Things which we already know. We need to see it in anatomical position. Now, those who have joined sometimes afterwards, one good email that do ask us questions. So definitely, I'll be asking you more questions. So just for the sake of those who have joined later or those who have joined after we discussed the anatomical position, anyone who can tell me what is anatomical position, please unmute and you can start. Anyone? I won't be taking any specific name. खुद ही बोल दो ना. Sudhanshu. चलो, Sudhanshu. Yes, start.
Horizontal position.
नहीं दोस्त, anatomical position. What I'm asking is, what is the normal anatomical position of the entire body? ठीक है?
Okay. Palm facing forward, legs together, standing straight, or
अच्छा. Okay, Sudhanshu, hold on.
So standing straight, face looking forward, arms on the side and feet together.
Right. So person should be standing straight, arms on side, palms facing forward, looking straight.
Feet parallel.
Feet parallel. Correct? Feet parallel.
Flat on the ground.
Correct. So this is the anatomical position. Now in this, whenever we say that when we learn bones, so then they'll say that, okay, take the clavicle, put it into anatomical position. When this question is asked in Viva, you will see that clavicle and then you will put it and you will hold it how this bone is present into your body. Right? Remember, examiner is asking. So he will be watching you. So if this is the right clavicle, you will say that like this, that this is the anatomical position. Okay. What we are watching now, as if patient is in front of us. So whenever the question is asked to you and the bone is given to you, you will be holding as if how this bone is in my body, is in your body. How is it? Right? Because you are supposed to sit, stand in anatomical position. That's what examiner is expecting. And he's telling this bone is how. So that is anatomical position. So we'll be holding it horizontally. Okay, horizontally. When this is like a tube, this is also fine and this is also fine. Okay. So let's solve. This is clavicle. Clavicle means in Latin language, it is small key, choti chabi. Whenever we say key, so that means there is one flat end and second end, it's a round end. Then it becomes our responsibility to figure out which one is flat and which one is round. Immediately we find that yes, this one end is quite flat and this is rounded. So that's why they must be calling it a key. नाम तो देना ही है कुछ, let's give the name something which is making the sense, right? Otherwise in China, the way they drop the spoon on the floor and the sound comes ting tong, right? So that is the sound. So that is the name. So for remembering it, bhul na jaye isliye, lateral is flat. You'll always remember lateral is flat. So lateral is flat, so medial is round. So far so good. But again, it is a tube. If it is like this, so this is the medial. But when we do it like this is again a medial. So that's why it is necessary that we have to find out what is above and what is below. And there we find that when we feel the bone over here, it is very smooth. So that is superior is smooth. Superior is smooth. But the inferior surface is with so many landmarks. One of the biggest landmark is prominence. Conoid tubercles. This is something which you cannot miss. You close your eyes and you feel both the end, the upper is very smooth. Below it is rough, right? This area, that is rough, and because that means there is groove, right? You'll be able to feel the groove. Because most of the events, they will be occurring below. So here it is. Now you are clear that there is one surface which is below right? So if this is a clavicle, let's say this is rough surface, this is below. Now this is medial, this is lateral, so there can be only one possibility that this is a right-sided bone. Got it? So this is for the side determination. Every bone, whatever you will be learning, will be telling the side determination is important, right side or left side. That is one. And second, in its anatomical position. No one will give you the vertebra and then they'll say okay, side determination, right? In vertebra. The toughest thing would come in when it comes to skull bones. Skull bones, when they give that. Because then at times there are 4 or 5 points which you have to really look at. And there is one bone, you know the name, pisiform, right? Now that pisiform itself is such a small bone, so इसमें तो blunder ही हो जाता है. So that's why I take a wild guess. I think I told my teacher did just toss the bone ऐसे ऊपर उछाला, right or left? I said right. It turned out to be right. फिर तो बोन हाथ में है तो then you are the boss ना, क्या रे यहाँ से ऐसे करो because of this facet and this the thing. गलत निकलता तो सर ने पूछा भी था, गलत निकलता तो I said all time best word, sorry sir. So this is the grooved surface. Now there is one point, the curves meet medially. This is how it is. When we watch, so this particular bone, right, say this is like it is, right? The curves, they meet medially. This is as such an S-shaped bone, S-shaped. So this point, that is the point of interest because that is the point which will be transmitting the side pressure, right, to the axial pressure, to the axial line. That is the peripheral pressure. If you lift anything from your hands, so then it has to be grounded with the feet, so the pressure would be transmitted. And this is the weakest spot, that is the lateral 1/3 and the medial 2/3. This is the point where the bone can really break easily. But this curvature, same way the opposite side curvature will be there, and that's how it meets. In last batch, someone told me about that this bone is also called as the beauty bone, right? Beauty bone. Because if the entire clavicle is seen, it is considered as very beautiful. Now, I don't know. Not sure. But all these Korean and Chinese serials, I mean, they are so skinny that all the bones, they are visible like this. Okay. The peculiarities. The next question which will be coming up will be this. Right? They will be in Viva, they will be asking you this. If you have done anatomical position correct, you have done side determination correct, and then the next question will come up that what are the specialities or the peculiarities of this bone, and you have to remember all of them, right? Because all of them, they are very classical. One, it is a horizontal bone. ठीक है, horizontal long bone, मान लिया. It is subcutaneous, yes, because it is underneath the skin, you can feel it. It is the first bone to ossify, very important from the forensics point of view. So once you take the X-ray, and in this X-ray, we find the entire clavicle is seen, so that means that person has at least crossed 2021. It has crossed, right? This comes in the form of membranous ossification. That means it has got no medullary cavity. Long bones, they have got the medullary cavity and the cortex, right? So medullary cavity, which is inside, which makes bone marrow, and RBC, it is the production house for RBC, WBC. While this cortex is tough, this friend has got no medullary cavity. Remember that. So this means it is like a rock bone, solid bone, only bone, right? There is no bone marrow. So do remember this. It develops in the form of membranous ossification, like a pyaj, right? So like onion, 1 layer, 2 layer, 3 layer, 4 layer, it keeps on forming. And that's how the bone becomes tough, right? So it is the membranous ossification. Layer by layer, they'll keep on forming. So that's how the membranous ossification occurs. We just come to this ossification. This is pierced by middle supraclavicular nerve. The nerves will be passing through and through this bone, right? So they are the middle supraclavicular nerve. Not very much common in any other bone. nerves will be winding around those bones, but they will not be piercing through and through, right? This is the bone where you'll find the nerves are piercing through and through.
Whatever, Guruji.
Yes?
Mm.
You are unmuted, Shraddha. So now there are two primary centers of ossification. In ossification, correct. In ossification, we said that initially the entire bone is formed in the form of cartilage. So that is what lays the basic structure, and then gradually they start becoming bony. So in that primary ossification and secondary ossification centers, primary ossification centers are those centers which are developing before birth, that is intrauterine life. So there are two primary ossification centers in this particular bone, which are in the center. These are the two primary ossification centers. So as such, you are not supposed to take the X-ray of a pregnant female, but when you examine, right, on ultrasound, so you will find that the clavicle itself is very small. So, but in the center, you will see like those dots. Those dots, they are the primary ossification centers. That's how the bone starts developing. These primary ossification centers, they fuse, right? They'll become one. They'll become one by 45th day of birth. So after 1.5 months of, say, external world life, that is fused. Now, the secondary ossification centers, they will be carried. Now the bone will increase, right? And by the age of 15 to 17th year, the secondary ossification centers, they will start appearing. They are on those two sides, over here and over here. And then they fuse. So that means by the time you reach to the age of about 18, 19, that fusion is almost on the verge of completion. By 20th year or 21st year, it fuses. At the most 22, at the most. So that's why this is its speciality. Two primary ossification center, two secondary ossification center. Two secondary ossification centers, it's not a big deal in some of the bones, so you'll find multiple secondary ossification centers, especially when we'll talk about humerus. I'll show you some of the very interesting pictures when we come to humerus.
So, what is supraclavicular nerve present for?
What is supraclavicular?
Nerve present for, like, what does it supply?
Achha. Let the nerves stop, right? Let the nerves stop. I'll show you that.
Okay.
So these 7 points you need to remember by heart. Now see this. For next half an hour, I'll be showing you bones from all various angles. This is just to make yourself comfortable, because in Viva, they stump you on this. So here it is. Clavicle is there, right? First, what we see, this is the superior surface. This is inferior surface. This is the medial side. That's the lateral side, because this is rounded. We draw a line and person is standing in front of us. So yes, this is of right side. Am I clear in this?
Yes, sir.
Yes, sir.
So with this respect, we'll now start moving the bone. So here it is. When we are watching from the front, so obviously this will be the superior surface, this will be the inferior surface, and dead right front, whatever we are watching, that would be the anterior border. Okay? This is exactly like a box. Exactly like a box. So there is the superior surface, there is the inferior surface, and then this is the anterior portion or the anterior border. So what do we see in that? Conoid tubercle is our area of interest. On the lower border, we see conoid tubercle because that is what we use to identify. Plus there is, if we just touch, this is a rough area. This is a rough area, right? So that is what is called as the trapezoid line. Trapezoid line. Traps will be connected. So trapezoid line, right? Easy. And On the medial side, it will be connected to sternum. On the acromial side, it will be connected to the acromial process. So far, so good. We move further. As we are watching the anterior view, right, front. So front, this is the ridge, anterior edge or the anterior border, right? On anterior border, the big boss, pectoralis major. Now you can visualize, right? If this is the bone, so then pectoralis major, right? That was going like this. Right? That was going like this. So it was like this entire thing was like a pectoralis major. So this is pectoralis major and deltoid was giving the contour of the shape. So that's a deltoid. So that's at the lateral end. So no big trouble. In deltoid, we have written clavicular head. That means there would be one more head, and that head is acromial, right? Acromial. So this is the pectoralis major. On to
medial 2/3.
Yeah, that's it. That's right. Medial 2/3, right? Medial 2/3. Now we look at the posterior view. So now we are watching posterior view. Same bone, right? जैसे था उठा के ऐसे करते हैं. So now this bone, how is it? As if this is present into our body, right? As if it is present into our body. So this is the right-sided bone. So yes, that would be the midline. So as if it is present, so we have just taken the bone out and we are watching. So we are watching the posterior surface, posterior view or the posterior surface, lateral and conoid tubercle, all easy. Move further. So in posterior view, again, superior, inferior, and the posterior border, because we are watching from the posterior side. So we are watching from the posterior side. This is our lateral end. So lateral end is acromial end. That's entire thing is called as body, and this is the medial end which is rounded. Superior surface, inferior surface, all good. Now in this, when we are watching it from the posterior side, we come to know that there is a groove. This means this groove is more towards the posterior side, and this is the groove for subclavius. For this muscle, we were waiting. So this is the point, and see such a big attachment. Muscle is small, but it is attached because it is giving stability, right? It is giving stability. This is the sternal facet, right? Sternal facet. So from here, the sternum is connected. So it is our medial end. On the medial end, there would be ribs also, right? There would be ribs also. There would be ribs also. So this is the costoclavicular ligament over here, this portion, right? Which is absolutely, so when the clavicle is fit, right, ribs are there, it is immediately connected to the center. And so that's why costoclavicular, it is rib and clavicular ligament. So that is where it is attached, right? So if this is the sternum, when it is connected, ribs are already there. This is what gives the strength, costoclavicular ligament. So that's why it is connected like that. So we came across subclavius and the costoclavicular ligament. Obviously, costoclavicular ligament, that would be only on medial end. It cannot be on the lateral end because lateral end to acromial end will go to meet scapula. Yeah. Again, we are restricting ourselves to posterior view only. Absolutely posterior, right? Over here, we have got two good muscles. One, the sternocleidomastoid. Sterno is sternum, cleido is clavicle. Mastoid is that process which is just behind your ear, right? That big prominence which you feel behind your ear. The muscle which is coming all the way down, right? And it is meeting over here in the center. The muscle which is coming on both the sides. And over here, you can feel the trachea, right? You can feel the trachea is pressed up, right? So that is the trachea. This muscle is sternocleidomastoid. Sternum, cleido, clavicle, and then both of them, they will go up and will land all the way to the mastoid process. This is the muscle. In case if it is it goes into the spasm. It is called as torticollis, right? Torticollis. The name is torticollis. Person won't be able to move his neck. Torticollis. This is spasm of sternocleidomastoid. Now depends on which side of the muscle is paralyzed. Whichever is paralyzed and contracted, the neck would be bent at that point. So its function is bending of the neck, rotating of the neck, and then front bending. When both of them, they are contracting together, then it will say yes. So that's why this is one of the very powerful muscles, sternocleidomastoid. Connected on above? Yes, because that's the clavicle muscle ko yahan jana hai, right? Another muscle, trapezius, right? Those upper fibers, they will be going. So this is also quite easy, right? So this is the trapezius which is going. Now in trapezius, we were having like this situation. It is a kite-shaped muscle. So that means the down, right? Few fibers they are going up and few fibers they are transverse. So it is these descending fibers which will be landing on the clavicle, right? So descending fibers, right, they will be landing on the clavicle. So this is the trapezius part. Below subclavius, we have already talked about. Sternocleidomastoid we know, and this is sterno and the hyoid bone, right? Hyoid bone, that is quite near, right? See, hyoid bone, that prominence, right? So that hyoid bone is near, so they both attach. So they both attach. So that is the sternohyoid. All these are, we are watching the posterior view, right? पीछे से. Now this is clavicle. We are going for the superior view, as if you are watching from above. As we are watching from above, you just see as it is in your body, how it is in your body. This is a flat. This is, sorry. And this is the right side. So this is the right side. This is anterior, right? This is anterior. You are watching from the top, superior view. And the smooth surface is what you are watching. Obviously, this is the acromion. The acromion end is a flat end. Sternal end, acromial end, flat end, body, you know that. This is superior surface, so there will be anterior border, posterior border. Okay? So something which is on the top. Now see how wonderfully we can see this sternocleidomastoid. It makes now complete sense. Ke bilkul aage se, right? So that's why it is on the top. Thoda sa portion piche se dikhta tha, but it was just a glimpse. Pura muscle to yahan baitha. And the trapezius, the descending fibers, yes, they are over there. But see the differentiation. Till this point, we were understanding that yes, trapezius is connected, but when we watch from the top, traps is a back muscle, right? Traps is a back muscle, neck muscle, in fact, we should be specific. So that's why it is connected over here. And deltoid, it is going to give the round contour of the shoulder. So that's why it is over there. So there is a clavicular head, clavicular part, right? Because it is emerging from clavicle, so we'll call it clavicular head. There would be the acromial process also, so we'll call it acromial process or the acromial part of the deltoid. And deltoid covers from the big surface. And deltoid is powerful because this is where we drew the middle fibers. And these middle fibers, they focus on small area, and that's why this whole thing gives better strength. It is called as the multipinate muscle. Okay. The costoclavicular ligament. Now we are watching on inferior, right? Like a car mechanic, right? We are just watching from the inferior. But then one surgeon got the habit कि patient को उल्टा करने का, table में hole करने का, and then do the surgery. People used to wonder कि क्यों ऐसा? क्योंकि वो पहले car mechanic था. Then he got the admission in medical college, but वो आदत गई नहीं. So इसीलिए he operates like this. So this is the costoclavicular ligament. But it must be an art, na? So this is the medial end, this is the lateral end, and the rib which is getting attached. Right?
सर
हाँ.
अगर जब ये क्लैविकल ब्रेक होता है या फिर फ्रैक्चर होता है तो सब इस मीडियल मीडियल पार्ट से होता है ना,
Hmm.
तो वहां पे जो सब क्लैविन वेसल्स है वो सब जो भी है ब्रैकियल प्लेक्सस वो भी डैमेज होते होंगे.
हाँ, if it is damaged, it's a major problem. You are right. If the clavicle is damaged, but see what happens is, just a minute, so many messages. हाँ, मतलब I mean जब when the clavicle breaks, and in case if it has damaged more of the things, right, more blood vessels or the brachial plexus, it is your duty to repair whatever is broken. But as such, you will find that यहाँ पे the muscles, they are so powerful, right? If a patient comes and says that he wants to remove his false ribs permanently, false ribs, नहीं, it वही मैं बोल रहा हूँ, false ribs are not made in China. वो तो काम की ribs हैं, right? Rib number 8 to 10. No patient has ever come के मेरे ये ribs निकाल दो. काम की ribs है, उसको तो गलती से false name दे दिया है. Okay, they are not false. Ribs जो निकाली जाती है, they are cervical ribs above, right? Which are emerging from the cervical region. So that is painful. You are cute. That question is lateral side is attached to shoulder. Ah, lateral side is attached to shoulder. That's right. Good morning. Clavicle is the weakest bone. हाँ, ऐसा तो you can say clavicle, but it is not as weak. हाँ, जिस दिन clavicle हाथ में आए तोड़ के देख लेना. Not easy to break. It is
Sir?
very tough, but it is relatively. हाँ बोलो.
अगर यही बोन्स मतलब यही क्लैविकल बोन पास करवाता है ना ये फोर्स और या फिर जो भी वेट है टुवर्ड्स द एक्सियल इसके पास रिब के बोन बैकबोन के पास, तो वो इतना सॉफ्ट क्यों है?
It is not soft. दिखने में soft लगता है. बाकी तो मैंने वही बोला, तोड़ के तो दिखाओ, पता चलेगा.
नहीं पर उसको सॉफ्ट बोलते क्यों है अगर
It is
पूरा
as
वेट पास कराता है?
the reason is see this bone. Right? The weak bone किसको बोलते हैं? That is what we'll see in skull. The bones are papery thin, literally. If I give you the bone in your hand and if you do like this, tuck, you'll break the bone. With a finger knock, you'll be able to break a bone. They are that delicate, but still they are there because we know that they are surrounded by such structures which themselves are very weak, right? So they don't need someone very tough. It is a very protective area which is to be made. That's the whole idea. So all those glands, all those nuclei, right? All those very delicate vessels, they are safely sitting over there. The function is that they are just creating the partitions for, like, say, pterygoid bone. There will be something like pterygoid. Medial and lateral pterygoid plates. Now those plates invariably, मतलब जब even देखते भी है ना, images में तो ठीक है, images में तो we can see that, but practically if I show you that bone ना, एक आध pterygoid की वो plate तो टूटी गई होती है. It is so difficult to see that. So difficult. Styloid process. as such देखते हैं कितना बढ़िया styloid process है. But by the time when you start removing the muscles and you dehydrate that skull, कई बार एक बाजू का styloid process टूट जाता है. But clavicle, never. Clavicle, look at it. It is giving such a strong base and it is connected with those mammoth muscles. The muscles themselves, they don't allow it to break. So that's why the clavicular fracture is considered as a very mamuli fracture. Though we say, करे boss, brachial plexus is going. हाँ जा रहा है तो जाएगा ना. Those scalenes, right? In osteology we'll study it more. But those scalene muscles, scalene anterior and scalene median, क्या मस्त खींच के रखते हैं that much portion of clavicle. उतना portion रखेंगे, right? So that window remains patent. Clavicle का जो होना हो, right? तो ठीक है, मतलब दर्द हुआ, हाथ ऐसे हो गया, but brachial plexus is secured, right? So that's why the whole thing is designed. Because as you will start learning more and more, you will say, you'll salute to God, what an amazing construction. So you are right. This bone is relatively weak, but its fracture is considered as normal. सही में it is considered as normal. थोड़ा और treatment भी क्या, मतलब just rotate करके resolve it and give a plaster. बस bone will heal by itself. You don't have to worry about anything else. But देख लेना पड़े fracture हो तो whether the pulse is okay. You have to check the pulse on both the sides, taking together, so that you find that there is no pulse deficit. That is what you see. You just check the sensations. They are okay. कुछ चिंता नहीं. Nothing to worry. Resolution means putting the bone into its original position. Broken piece into original position. Rest is God give D3 and calcium. Khao piyo maze karo, don't move the hand and he'll be fine within 3 to 4 weeks. Right? After 6 months, so he can do boxing. No problems.
Sir,
Huh?
how can a fracture for clavicle be normal? Because clavicle is the one which is involved in the weight transmission to the lower part of body, right?
Huh?
So
What?
if that is not present there, then the axial skeleton and the appendicular skeleton
So
उनकी weight transmission.
that's why we need to repair the bone. Na?
Okay.
That's why we
मतलब
need to repair. In
it was
case if there is fracture, when there is fracture, right, this bone, it goes into this, and this bone goes like this. You need to squeeze and you have to put it into normal position. And then you have to put a plaster.
okay.
But if someone tells me my clavicle is fractured, तो Facebook के लिए and कहेंगे अरे यार ये वो sad face बना है. As a medical, you will say कि ठीक है, don't worry, take rest, you'll be fine. That's the thing. जबकि कहते हैं कि if there is skull fracture, तो people से कह रहे चलेगा, कुछ नहीं, जरा सा था. But then if there is any injury to the head and if there is no bleeding, तो बस just check yourself properly. Your neural examination should be done properly. Check all the cranial nerves. सब चल रही है ना? कहीं पे there is no pressure impact. And plus, immediately take the blood pressure. Immediately take the blood pressure. Keep on taking the blood pressure at regular interval. There should not be any change. Plus the signs symptoms of raised intracranial tension. That can you see the things properly? Yes. Is there any vomiting, nausea? No. Right? Blurry vision? No. Right? Headache, and that also the generalized headache. Is the person feeling drowsy? If not, so that means the raised ICT, intracranial tension, is not increasing. That means there is no chance that there is any bleeding. But out of all these things, even one thing is appearing, rush to the CT scan. Rush to the CT scan. खुद जाके सो जाओ, right? Machine शुरू करो, check it, and whether there is any hematoma or not. In case if there is hematoma, so then there are specific hematomas which gets collected into those areas. And one of the common is tarion, right? So over there, if it is there, so it has to be operated immediately, right? Bar hole, and then that tube, and it drains the blood. Then rest of the things it can be managed, but that life-threatening thing is gone. Person should never go to sleep immediately if there is any head injury, because then he won't be able to complain in case if any of the sign symptoms are appearing. Right? All right. I just removed this pterygoid, right? It might create confusion. So this is the costoclavicular ligament lateral. Here it is. Trapezoid line. Now we are watching the inferior surface, right? Inferior surface, and in which we are watching what is attached. So this is groove for subclavius. That is what is making that entire inferior surface rough. Baki tha to this conoid tubercle. Or tha to this trapezoid line, because this trapezoid line is where the trapezius will be installed connected. And this costoclavicular ligament, कब से बोल रहे हैं, right? This is the sternal and medial end to costoclavicular ligament. This is also rough. Now we know that why the inferior surface is rough. Over here, the pectoralis major and the subclavius. So what we watched over here is the bony prominence. This is groove for subclavius, and the subclavius will be attached to that, right? Trapezoid line, so trapezius will be attached to that. Pectoralis major was on anterior end, but some portion it comes even on the posterior aspect also. And then that thin ridge which is over here, right? It is not thin. Deltoid is connected, but the deltoid will be going on the other side. So this is how it is connected. But this is me, subclavius and the sternohyoid. But those major. Now we move on to the scapula. Scapula is irregular bone, right? Also, it is called as the triangular bone. I'll be back in a minute. I'll just get water. Just 1 minute. Okay. So this is scapula. In scapula, again, anatomical position, the easiest one. First, you just determine which side it is. Now, in scapula, as such, if we watch from the side, on one side there is spine, and second side, it is smooth. This spine is where? On the back, because we feel it, right? So this means this will be the posterior surface. This one would be the anterior surface. And then there is one portion which will be connecting to humerus. So this glenoid cavity, so you can't miss, right? So you have got the glenoid cavity and you know what is anterior, what is posterior. That's it, sufficient. Right? So when it is said that put it into anatomical position, what we'll do is we'll take this scapula and we'll put it in such a way so that the smooth thing that should be facing anterior. That should be facing anterior, right? So now when we do this, right, patient is in front of us. Patient is in front of us. So this is the anterior surface, right? This glenoid is the lateral side. So this is the medial side. The midline is here. So this is the right side. Easy. After that, you can do all sorts of katha. This is the acromion process, this is coracoid process, and this is the superior angle, and this is the inferior angle, and this is the glenoid cavity, and it is the lateral angle, and whatnot. All good. But side determination, clear, right? Put it in your body. You know that. So coracoid process, acromion process, that is what is called as the glenoid cavity or the head, which is shallow. Very good question. Where do muscles attach if someone has got cleidocranial dysostosis? When the muscle, when there is cleidocranial dysostosis, clavicle is not absolutely absent. Right? I got a wonderful X-ray. I'll just keep a note on it. X-ray.
So like this example, this thing is also given in BD Chorasi also.
Because in cleidocranial dysostosis, right, the bone itself is so thin, so small. So the muscles will be attached on that thinned version, but that muscle won't be able to give support. There are multiple stages of CCD.
Okay, sir.
अच्छा, now I know. जब ये CCD बोला तब याद आया. Someone said Coffee Cafe Day का CCD बोला होगा. I kept on thinking ये cleidocranial dysostosis क्या है? Why it is that? Seriously. So all easy. Lateral angle, superior angle, then inferior angle, all good. Medial border, yes, this is the medial side, this is the lateral side, and this is the costal surface or the anterior surface. And the superior border, yes. ये एक देख लो. In not seen properly, here it is seen. There is something what is called as the suprascapular notch. This is the suprascapular notch, right? This one. So it is the notch. This is the coracoid process. So in this notch, when we see this, obviously this is the anterior view. Right? Which side is this? Right or left?
Left.
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 So here, this suprascapular notch, again, this is a Viva question. They'll ask you for this question. So suprascapular arteries and veins, they pass above, arteries above, right? So this is like we say army above and the navy below. So nerves are below. Nerve is below. Suprascapular nerve is below, and this is above. Now we focus on the acromion process, a big process, acromion process, right? So this is the acromion process. And on that, there is a supraglenoid tubercle. I'm sorry. So this is the acromion process. There is supraglenoid tubercle. There is infraglenoid tubercle, right? And this is the subscapular fossa. Subscapular fossa, correct? Subscapular fossa, because this is what we are watching. This is anterior, right? It is flat on the chest. And from here, the subscapular muscle will be passing. Subscapular muscle, which is part of the rotator cuff, right? And we write it like 6. Supraspinatus, infraspinatus, teres minor, and subscapular. So subscapular. This is the glenoid cavity. Regarding this inferior scapular notch, just hang on a while, right? I'll show you something. Because it is not seen over here. You can't see it from this side. So suprascapular notch is clear, correct? Suprascapular notch. This is from the triangular region and you are watching it. And when the body is absolutely front. Here it is. This is the infrascapular notch. Normally, no one would call it as an infrascapular notch. In some of the books, it is mentioned because now the name has changed to, aka also known as spinoglenoid notch. It is also called as the spinoglenoid or the greater scapular notch. Greater scapular. What it really does is, in simple words, supraspinatus, infraspinatus. That's what it connects. Supraspinatus, infraspinatus, and it would go like this. Behind this curve, that is infrascapular notch or the spinoglenoid notch. Spinoglenoid is more appropriate because this is near to the, because this is the spine. sorry. This is the spine and this is the glenoid. The glenoid, right? So spinoglenoid notch. Right? And as such, we understand that it is the communication between supraspinatus and the infraspinatus region. So this, in this we'll see 4 things. The glenoid is seen. So we are happy with the glenoid, right? Okay. This is the glenoid. Just above, there is small tubercle. That means small prominence, small round prominence. So small tubercle, and there is a small tubercle below. So here, if it is, we say this is the glenoid. So there is one portion above, there is one portion below. This above one will be connecting to biceps, and this lower one will be connecting to triceps, right? But over here, yes, because they have to travel so much. So that's why they're long head of biceps and long head of triceps, they will be going. Biceps, we have got this long head, right? So this is where all the weight comes because this area is not easily approachable. There'll be humerus, right? So yes, from there all the way to travel and it will come over here. Triceps, this from all the way it is coming over here. Got it? Right? So that's why, because they have to travel so much, that's why we call them the long and the head of biceps and the long head of triceps. Supraglenoid tubercle, infraglenoid tubercle. Biceps, triceps, we talked about. All good. Right? Supraglenoid tubercle, inferior scapular notch. Right? Then infraglenoid tubercle. Yes, it is that. Now, purely the muscle attachments. Pure muscle attachment. So here, from this point onwards, I'll stop writing that which view are we in. So this view is, which view is this?
Anterior.
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 Anterior. Because spine dekhi nahi, spine is back. So view is interior. Okay. So that's why this is subscapularis. Chalo, fine. On side. Which side? This is lateral. So on the medial aspect, right? We have got
Right
the
side.
hanging serratus anterior. So serratus anterior is attached. The area in which we are very much interested is this coracoid process. Right? Kab se ye coracoid process was talking about. So this coracoid process, it is divided into two parts. The above part is biceps brachii, below part is coracobrachialis. That is how it is attached. And on the back side of it, there is pectoralis minor. So here, pectoralis minor, it goes like this. Right? That's how it was going. And it was doing what? Which vessel it was defining into its three parts?
Axillary.
Axillary.
Axillary. First part,
Axillary.
second part, third part. Right? Yes, I got recordings, but yesterday I didn't really open the email and checked it. I got your recordings. What is the functional importance of the coracoid process? Now you know. You asked the question and now you know the importance. Functional importance. Because coracoid process is that part where biceps and coracobrachialis, two big muscles, two important muscles, they are connected. So scapula, anterior. This is posterior view, no big rocket science. Supraspinatus, infraspinatus, there's the fossa and the acromial angle. What is this? This one is what and two is what?
Suprascapular notch and infrascapular notch.
Shabash, right? Superbly seen suprascapular notch. So then it will be converted to suprascapular canal. And that's how the artery and nerves will be passing. And this is the infra or the spinoglenoid notch or the infrascapular notch. Right? And this is supra. Should I write or it's okay? You know that.
We know that.
You know. Okay. All good. Coracoid process, acromion process, head, neck, body, spine. This is chalo, aa gaya, right? So superior scapular notch or the suprascapular notch, superior angle, inferior angle, and the lateral angle. Right? Superior angle, inferior angle, lateral angle, and we have got the dorsal surface. Dorsal surface means posterior surface. Okay? Posterior surface, so no confusion. And that's the neck. That's the neck. This name is coming out. The acromion process, which is flat and it goes down, it takes turn. When it takes turn, to be called this thing, this angle as the acromial angle. Right? This is called as the acromial angle. So during surgery, right, many times you'll be coming across that put a small nick near the acromial angle and flip the muscle. So that's from that importance, we should know. Many of the areas of the bone, they are defined, their names are given, but their names are given with respect to surgery. That is when you are doing the surgery, you have to define every step. So that's the point where you'll be having an important landmark which you can utilize for writing. Right? So this is the inferior scapular notch. Then we have got the supraglenoid tubercle and the infraglenoid tubercle. Infraglenoid tubercle, that is where long head of triceps, and obviously supraspinatus and the infraspinatus fossa. all muscles, and you know all of them. Beyond doubt, you know all of them. Let's pick up the easiest thing first so that they are finished. Supraspinatus, infraspinatus. सोचने की जरूरत नहीं, right? Then in the back, when scapula was here, we found that some muscles, they are connected like this, and they were even on the opposite side also. And we were very happy. हाँ, आ गए. That's rhomboidus major and the rhomboidus minor, right? So this is the rhomboidus minor and this is the rhomboidus major. They are connected on the medial border, right? This is the medial border. Medial border. That one. So this is also clear. On top, above, right? This area, so it is like super reserved area. If the levator scapulae pulls, so right, it is as if चूहे को उठाया उस तरह से, right? So that is the levator scapulae. So that is the levator scapulae which is over there. That's what I used to feel. जो दिमाग में आता है वही मैं बोल रहा हूँ आपको. मैंने सर से भी पूछा था, सर सुपर लेवेटर स्कैपुला सिर्फ अकेला हो तो ऐसे उठाओ तो वो चूहा उठाए ऐसा ना. Said yes. Then on the medial side, on the lateral side तो all of them long head of triceps, teres minor, teres major. Okay. So clearly on this above part, यहाँ से easiest muscle, so there is only one, right, which is giving this cut of the neck, right? So that has to be trapezius. Descending, transverse, ascending, every fiber comes over here. Right? This is the selfie of infrascapular notch. This is selfie. ये पोज देने के लिए scapula must be waiting since long. So now that's what is called as the angular view. In radiology, when some fractures are there, right, and if those fractures, they are very subtle fractures. Subtle means they are very delicate fracture. Some fractures, they are like hairline fracture. In such cases, you have to go for these odd views. So they are called as the angular view. Right. So whenever patient would also tell you कि ये क्या circus करा रहा है, but then you would say you put your hand, बस इतना ऊपर इतना नीचे, and then you adjust, and then हिलना मत, right, and then you take the shoot. So they are all called as the angular view. The lateral, neck, inferior angle, body, all good. Here it is. So that is the inferior scapular notch, infraglenoid tubercle, supraglenoid tubercle, supraspinatus, जरा सा दिख रहा है. This is the infraspinatus, but from यहाँ से we go there, acromial angle, all known. This is also easy, right? Acromial angle. So this is the infraspinatus. We have got the long head of biceps, short head of biceps, a long head of biceps, long head of triceps, right? Long head of triceps over here, and it goes all the way like this. And then the deltoid. See the deltoid. Deltoid, this is the acromial part. Can you see such a big area, right? It goes all the way. So this is the short head. This is the deltoid, the acromial part. And on the coracoid process, we got the short head biceps and the coracobrachialis. Now it is better. Now it is better. So deltoid, and this is short head of biceps and the long head. This is really something which is over here. Right here, the cursor has come. The spot. यहाँ दिखा देते हैं. यहाँ पे है, right? Biceps and the coracobrachialis. Wait, there is one image. Okay, let it come. Where in one image you'll be able to see everything. So let's name it as 1, right? Short head biceps. Let's name this thing as 2, So this is coracobrachialis. And just over here, this is 3. That is the long head of triceps. Right? But I'll show you in one image, everything together. So it will be much more clear. This is clear. Acromion, clavicular, and the head of humerus. Okay. Though humerus is not our today's topic, but we are just watching for some clarification. The surfaces, when they move, when we define, right? Then we say this is the anterior surface, this is the posterior surface. But sometimes it happens that posterior surface, it is smooth and it gracefully comes slightly on the opposite side. This is what has happened here. When we say this is anterior view, right? Dikhta hai, this is anterior view. And then over here in this area, we are writing it as a posterior surface. How come? The reason is that posterior surface is so smooth that it comes, small portion comes over here. So anatomist felt that okay, yahan pe bhi we'll just call it posterior surface. No need to define something extra. The anterior surface, there is no anterior surface. Anterior surface is like an anterior ridge, right? It is like an anterior ridge, a prominence. So it divides the whole bone into 2 surfaces. So that's why this one is called as the anterolateral and this side is called as the anteromedial surface. If you want to say surface, then this surface will be comprised by anterior, anterolateral and anteromedial. You got it? If you are watching a cone, तो ऊपर से देखो, so this is lateral and this is medial, and so anteriorly we'll call it anterolateral and the anteromedial. Just a second. Yes. And so that's why it is called as the anterolateral and the anteromedial. And this is the anterior, what we will call anterior ridge, right? Anterior ridge. So greater tubercle, and the lesser tubercle. Greater tubercle, lesser tubercle, right? And in between, this is intertubercular sulcus. Okay. As we go down, so this is the area which we call as the surgical neck. Okay. Surgical neck. You know the importance of surgical neck. And then the deltoid which was attached over here, it comes all the way right this much. And then if you feel in your arm, right, when you feel the deltoid, you'll find that almost to the middle of the humerus it is going, right? So this is what is called as the deltoid tuberosity. Tuberosity means it's a big area. Tubercle was a small area. Supraglenoid, this is a small area. Infraglenoid, this is a small area. But when we say tuberosity, it's a big area. So this is the area where the deltoid would be connected. And because deltoid is a powerful muscle, that's why it will be creating a lasting impression on the humerus. So this will help us that, okay, this is where it is to be seen, right? A very prominent area. Surgical neck, what passes? Axillary nerve and the posterior circumflex humeral artery. Here it is. In one image, we have tried to put almost everything together. So let's see it like this. The clavicle, right? First we start with pectoralis major. So that's entire area, right? Pectoralis major, pectoralis major, right? So this is the clavicular head. This is the sternal head. All of them, they are going over there. And pectoralis major, right? It is connected to this area. Here it is, right? That's the pectoralis major. Lateral edge of the intertubercular sulcus. Perfect. Right? So that is done. So pectoralis major will be finally covering everything, right? From this big area and it goes over there. So if it has to cover, so it will cover everything. So all will be covered. So we remove the pectoralis major for our understanding. Right? Removed. Now we go deep. We find that over here, this is this one, right? So that is the latissimus dorsi, lats. So that is over there. And teres major, which is present over here. And this teres major will be coming from the backside. So that is done. This is subscapularis. Yes, this is like that sandwich muscle. So here it is. Here it is. When we focused on these intertubercular sulcus, this is above that. And that's the area where it will be connected to subscapularis. Right? So that is done. Next, coracoid process. This coracoid process, which is divided into two parts. This above part is the short head of biceps, and this one, this is the coracobrachialis. So in order to see the coracobrachialis, you have to actually remove the short head of biceps because both of them, they are like this. Right? So we remove the short head of biceps, and underneath, just over there, is the coracobrachialis. Just near the coracobrachialis, this is the pectoralis minor. So this pectoralis minor, which was like this, right? So that's the pectoralis minor. And we have got the coracobrachialis and the short head of biceps. Rest is all, say, regarding the clavicular head. See, so simple because this whole muscle is going, right? So this is the acromion process. This much is the clavicular process, right? This much. So it is called as the clavicular head, and this portion is called as the acromial head. Right? And all of them, they will be landing on deltoid tuberosity, right? Deltoid tuberosity over here. Eventually, in the lower half, we'll come across another big powerful muscle, and that is called as the brachialis. That is the muscle which we'll be watching over there. And this is the coracobrachialis. Because it is going for coracoid process, it is called as coracobrachialis. This brachialis is a dedicated for arm, and we are calling it just brachialis. Acromion, humeral, right? And this is the greater tubercle. Greater tubercle. Now everything is crisp clean. This is the superior surface of clavicle is what you are watching. This is the acromion process, right? That's the acromion angle. This is the angle. Got it? The angle which we are talking about. This is the acromial angle. And the head, the posterior surface, see the posterior surface, how big it is. And it is this surface which is slightly winding on going on the opposite side. Anterolateral, as such, it is a large surface. It has to be large, right? So deltoid tuberosity is over there, such big areas, big muscles, brachialis will be there. So anteriorly, so that is the anterolateral border. So if you take a cross section, so you'll find that it is something like this, something like this. It is not a complete round. Right? It will be having anterolateral, anteromedial edge, and then the louder. So this is how the muscle would, the bone would look like. Supraspinous, infraspinal spine, accruement process. So surgical neck, all we know. Now we are on the posterior side because spine can be seen. And on the posterior side, it is this radial groove which is showing us that yes, the radial artery will be passing through. Artery or no?
No.
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 All muscles, supraspinous, infraspinous. Right. This is teres major, teres minor. So right, they are very close. So that's why the different color is not seen. But this is teres minor, and this thing is long head, triceps. Right. Similarly, this is the lateral head, and here is the medial head. So medial head triceps, lateral head triceps. And the brachialis, which goes down. Sternocleidomastoid, right? That is the clavicular head. It is now everything on the anterior side. And this one is the trapezius. In trapezius, we say that descending fibers, transverse fibers, ascending fiber. See, the fibers which will be coming from the top, fibers which will be coming like this, and fibers which will be coming like this. That's how the trapezius is formed, right? Descending fibers, transverse fibers, and the ascending fibers. Now this is from the drone's view. So sternocleidomastoid, it will be coming up, right? And that's where the trapezius. See, this is the differentiation. So for over here, the descending fibers. Then over here, the transverse fibers. Then all those ascending fibers. Similarly, lateral and medial triceps, they can be seen. And over here, this on the tip, this is the scapula, just on the tip, levator scapula.
David.
So we rotate the whole thing in such a way that at an angle, now see, this is anterior, right? So we are watching it at an angle. Angle is absolutely facing towards this medial border. So it is this medial border where we see this levator scapula. Then we have got the rhomboides minor, and then we have got the rhomboides major. And lateral and medial head of triceps, so they are just from the shape itself, you can see this is the lateral, and this is the medial head of triceps. All right, so done. That's it for today. Achha, important thing is on Saturday. On Saturday, we won't be able to meet because I'm in Mumbai. And so now we'll be meeting straight away on Tuesday. Right? Once I return, I'll message you. But definitely by that time, I'll surely be back. We'll meet. All right. Wish you a very happy weekend. Take care.
Sir,
Thank you, sir.
Thank you.
Thank you,
sir,
sir.
Yes,
So
yes.
will
Go
you
ahead.
be
The-
having the meeting on Sunday?
No, Sunday I am in Mumbai.
Okay,
So I'll let you know which Sunday we are planning.
okay.
sir, the coracobrachialis has similar function like brachialis, like they both share.
Brachialis will be going down. Right? Brachialis is a very strong muscle, very powerful muscle. Once you will see that brachialis, it is such a powerful muscle. that in the brachioradialis. Now you know brachioradialis, right? So from there will be one more muscle. From arm, it will be going to the radius.
Radius.
Right?
Yes.
So thus the whole pack looks like coracobrachialis, brachialis, and the brachioradialis. So there is
Okay.
one attachment above, one in middle, and one which is going below. So that's how the whole exercise, I mean the arm is defined.
Yes, sir.
All right. Take care.
Hello,
Thank you,
sir.
sir.
Thanks.
Thank you, sir.
Thank you.
Hello.
Thank you, sir. Thank you, sir.
Thanks.
Thank